This is Liz Buttry. We will be presenting on relapse prevention. Our presenters today are Dr. Dennis Daley, the Chief Addiction Medical Services and the PI for the Appalachian Tri-State Node. We also have Dr. Dennis Donovan, who is the Director of the Alcohol and Drug Abuse Institute and the Principal Investigator for the Pacific Northwest Node. We will be taking questions for the presentations. We encourage everyone to use the Q&A feature, which you will be able to find at the top of your screen. If you click on that box and hit question and hit ask or hit return, your question will be populated into that feature, and we will handle it at the end of the presentation, but we will be checking that periodically. Before we get started, I'd like to go over a couple polling questions just so we can get to know each other. So I'll go ahead and go to the first polling question now. In which type of setting do you work currently? Hospital detoxification, residential rehabilitation, psychiatric, hospital, dual diagnosis program, partial hospital or intensive outpatient program, outpatient or continuing care program, specialty programs such as an opioid or some other type of program. The polling question is now open. We'll start collecting results. I do recognize we have a large number of people joining in as groups and may not be represented in the polling question. I'll go ahead and show the results right now.
Okay.
Looks like we have about 50% that are with outpatient or continuing care programs. I'm going to go ahead and move to the next polling question. How long have you been doing clinical care in the field of addiction? 0 to 1 year, 2 to 3, 4 to 5 years, or more than 5 years? The polling is now open. Go ahead and show those results. Like we have 37% that are 0 to 1 year, 20% 2 to 3 years, 16% at 4 to 5, and about 25% with 5 or more years.
Great.
Thanks, everyone. I will go ahead and return back to the presentation and turn things over to Dr. Donovan. It's all yours.
Okay, well, good morning, or at least good morning for those of you on the West Coast, from cloudy and overcast Seattle. So what we hope to do today is to provide you with really an overview of issues having to do with the clinical applications and the background for relapse prevention as a real method to try to help improve the outcomes of individuals with whom we work clinically. What we'd like to do is to just go over briefly what it is we will be focusing on today. The first thing we'll do, and momentarily we'll move on to, is to just briefly talk about how relapse prevention got started, and really the person most affiliated with that or associated with that is Dr. Alan Marlatt, who recently passed away, a good friend and colleague for both Dr. Daley and me. After which we'll go on and we'll talk about how it is that treatment and relapse prevention fit into the context of recovery more broadly. We'll talk about some of the definitions involved in relapse as they relate ultimately to how it is we can help prevent them. review briefly a number of evidence-based treatments that are available that really focus on relapse prevention, the models on which those are built, and then sort of go through a series of strategies, some that are at the systems level or the programmatic level, and then others that are much more relevant to the individual counselor as he or she works with clients and tries to implement relapse preventive strategies. So those are our goals for the day, and hopefully we will be able to get through that in the course of the time we have available. I'd like to start just by sharing briefly some of the history of relapse prevention. Dr. Alan Marlatt at the time was a relatively novice psychologist in training, actually, and was working as part of his internship in a program that dealt with aversive conditioning as an approach to treatment for substance abuse, alcoholism in particular. And over the course of the time that he was doing this, he saw many people who had gone through the treatment program and who appeared to have been quite successful, coming back shortly thereafter having relapsed. And at the time, it was not uncommon, and it still is seen, that substance abuse is an addictive disorder that is characterized by repeated relapses. Many people look at that and are discouraged because they say, you know, my gosh, what is it we can do? We're sort of given over to this disease, and relapse is our course and our future. Instead of doing that, Dr. Marlatt looked at it quite differently. He said, you know, people relapse, but if we were able to understand the conditions or the circumstances under which they do so, we would be able to help them in a way to anticipate and to try to prevent those relapses from happening. Or, if they do relapse, we can help them develop skills to sort of get back on track much more rapidly, that they need not necessarily go down a long course of continuing use before hitting bottom again and feeling the need or the ability to pull themselves out. And it was really his work and the work of colleagues with whom he worked, primarily here at the University of Washington, that started to develop the listing and the classification of relapse precipitants, and from that the development of interventions that really focus on coping skill development as a method to try to identify and to avoid or prevent relapse in high-risk situations. So both Dennis Daley and I have had the privilege of working with and publishing with Dr. Marlatt over time. He was my mentor. I was one of his graduate students. And we'd just like to commemorate his contributions as we talk about them today, as we have in other presentations that both Dr. Daley and I have made. Dr. Marlatt's had a great impact on the field, and his contributions have been massive, and his presence will be missed. So, having said that, moving on to the content of what we hope to do today. The first is just to provide some general background and grounding in the whole notion of recovery and where relapse fits and relapse prevention fits. One has to look at, the whole recovery process in the context of a chronic care model. In many instances in the past, still somewhat in the future, or in the present rather, treatment has been seen in an acute care framework. People come into treatment, the expectation is they're treated, they leave treatment, they should be fixed. It's sort of like thinking along the lines of going in with appendicitis, having an appendectomy, thereafter you should not have a problem. And that's a view that had been prevalent through the early years of the developmental phase of relapse prevention. And yet we're becoming much more aware relapse is one part of a longer-term process, as is the recovery process itself. And that while we really hope to achieve abstinence in the course of treatment and people's recovery, we have to look at it in combination with changes that they make and the growth that they make as in fact they broaden the scope of their horizons from substance use to a much broader lifestyle change. So really the goal is not just to get people to stop using, that's sort of our initial goal, but it's really to provide them with a broader frame of improving their health, their wellness, their quality of life, and making a much better life for themselves and those around them. And it's going to be a long-term process. This is a condition in the context of a continuing care approach or a chronic disease management approach, much like many other chronic diseases, that there will be periods of time when you will go along and do quite well, but periodically there will be ups and downs that we have to anticipate and be able to try to deal with, to prevent or to come back from. Obviously, as we know, treatment can help in that recovery, but we also need to be aware that not all people choose that as a goal. That may be our goal as individual treaters, but it need not necessarily be ones with which our clients agree. So this slide really tries to represent the percent of individuals that have been able to maintain abstinence throughout an 8-year period of time based upon the duration of abstinence at year 7. And the point that really is important is that, first of all, there are lots of people who are still able to remain abstinent 8 years out from the index treatment episode. I see that there it is. That it takes a while for folks to, in fact, be able to stabilize, and as will be shown later on, that there really is this sort of early phase in which relapse is most notable and most prevalent. But if people are able to stay clean and sober through roughly 3 to 5 years, the likelihood is great that they will be able to maintain that thereafter. So part of our goal is to try to maximize the likelihood that people can get through the initial rough spots that occur early on, stabilize themselves with respect to their recovery, and if we're able to help them do so, the chance is that they'll remain abstinent, and with increased abstinence, the likelihood of being able to sustain and flourish more broadly in that other quality of life arena is increased.
Okay,
so
go ahead. I'm sorry, Dennis.
I'm going to just hand it off to you, Dennis.
Okay. We're going to talk briefly about some setting the stage for relapse and addiction to build on what Dennis said. If you look at the stages of change, if you look at the early phases of change, we use more motivational interventions to try to get people engaged in treatment because we know that, for example, the majority of people with addictions never get help, and those who get help initially is for external reasons. They haven't internalized the desire to change. So the motivational strategies help in that process. So during the pre-contemplation and contemplation stages, often we use motivational strategies, we use assessment, and we try to match people to the treatment that may be best suited for them. And I think one of the problems we've had historically in addiction treatment is that we put people into the action stage when they're not sure they're ready to change. I don't think there's any easy solution to that, but I think nonetheless that happens. Now, the concept of relapse prevention was really developed to take place on multiple levels. One is during the action stage where you can provide education, you could provide some beginning skills to manage the challenges of recovery with the hope of reducing the risk of relapse. In the maintenance stage, I'm sorry, let me go back here. In the maintenance stage, the idea is that people have stable recovery, and this is defined differently. A lot of people in recovery would say that would be at least a few years. I think probably professionals in the treatment field would probably say, you want at least a year or two stabilize to help people really internalize a lot of the issues related to relapse. However, having said that, the topics and issues we discuss can be integrated during the different stages of treatment. And the relapse stage is very important. This is where, because you have significant rates of returning to substances after a period of sobriety, so we have to have interventions to help people get back on track. In fact, in my estimation, that's just as important as relapse prevention. How do you intervene early? The earlier, the better. Now, in terms of how we define this, in addiction treatment, we use the term lapse. That's, I drink or I use initially. It may be a few drinks. It may be a day or two, maybe a brief binge. Or I have a relapse where I continue to use. The pattern persists. In psychiatric treatment, and I just show you this just for comparison, they use the term relapse in the context of the current episode of treatment. So I get treatment for depression. I seem to be getting better, but then I get worse during this current episode. That would be a relapse. A recurrence would be I'm in remission for a period of time and my symptoms return. So you do have some differences in how this is conceptualized in psychiatric care and addiction care. Now, I won't go over all the definitions, but 2 points I want to make. One is, I think Dr. Marlatte's definition is a breakdown or setback and attempt to change or modify any behavior. The behaviors we're talking about here are addictive behaviors, but you can relate this to other behaviors as well. And the NIDA definition refers to it as a process. So what we teach patients is that we can look at this from two perspectives. One is the event of using substances, but the process that occurs before that. And I think that's been a significant intervention because when you teach people about the warning signs and indicators, if you help them learn how to manage these, they reduce the likelihood of relapsing. And as in any disease, you have multiple factors. It's not one factor, it's usually a combination of factors. And the categories, and the two categories, the interpersonal and interpersonal, came from the classification developed by Dr. Marlatte in his early conceptualization of relapse. And the interpersonal would be relationship issues. So you have support networks, you have conflicts, you have social pressures from other people, you have relationship issues with family, friends, anything related to relationships of a social network. The interpersonal are more internal, what we think, how a patient or client thinks, how they feel, how they deal with emotions, these sorts of things. And when you look at the issue of relapse, you have really a variety of manifestations. Sometimes it happens pretty quickly. Other times it's very gradual. The gradualness may be weeks, it may be days, weeks, months, or even much longer. And some of the other common factors we see are people that have indicators but they ignore them, or they have risk factors. It could be I feel depressed, or I feel bored, or I have pressure from someone. It's not the high-risk factor is whether or not they use an active coping strategy. And that's a point we'll stress throughout the talk, is the importance of coping strategies. And then you have family issues, and then poor adherence to treatment. Those of you who like Woody Allen, 80% of success is showing up. If you get people to show up for treatment or meetings, they have a better chance of gaining from these activities. Now, this is an important review done by McClellan and his group, where they compare different kinds of chronic diseases. And Dr. Donovan had stressed very nicely about looking at addiction as not an acute disease. It's a chronic disease for many people. And similar to other chronic diseases, you have high rates of relapse, but you also have a number of people who do very well. So you want to put this in perspective. Even if a person has relapsed and takes multiple episodes of treatment, that does not mean they are a failure. It means that they've needed a couple episodes of treatment. In depression, if someone has a recurrent episode of depression and the treatment's not working, they don't say you're not motivated. They say you have refractory depression. What can we do differently? And I think the same should hold true with addiction. And in the initial work by Dr. Marlatte, where he looked at some of the precipitants, these are some of the categories, and we just gave two samples. He's done it for other addictions, other substance addictions, and other behavioral addictions, just to show you some differences between alcoholics and opiate addicts. And so, for example, with alcoholics, it's the inability, not the negative emotion itself, which can be anger, depression, anxiety, boredom. It's the inability to manage that. And that'll be one of the strategies that Dr. Donovan talks about a little bit later. So this shows you some of the precipitants for the alcoholics. And just for the opiate addicts, and one of the big differences is the social pressures is much higher with the opiate-addicted individuals. And this speaks to their involvement in sort of the addiction culture, where you have more other addicts involved in their daily lifestyles. They have a different kind of pressure than some of the alcoholics may have in terms of other people pressuring them to use the substances. But they also have reactions to emotions, positive or negative emotions, conflict, urges and temptations, and things like this. So I think the main point here is that you have a variety of precipitants. They vary across clients, and it's usually a combination rather than one that determines whether relapse occurs. And this shows you, this is a classic study from the early 90s, the highest risk time is the first 90 days. Year one's the highest risk time, within that the first 90 days, within that the first 30 days. So obviously the importance of that first 3 months is very critical. And some of the NIDA publications talk about the importance of keeping people in treatment for a minimum of 90 days for them to show benefits. And we all know that in the mutual support programs, 90 meetings in 90 days has great meaning. And the effects may vary. I know a young man who spent 3 years in prison, went 6 months to a therapeutic community, got out, was clean from opioids, alcohol, and cocaine for a couple months, had like a 1-week relapse, and it opened his eyes. It motivated him. He reached a decision that, look, I got to do something like this. So that's an example of a therapeutic relapse. He actually used it to learn and to motivate himself. On the other side, you have the sadness of people who die from a relapse. It can be a drug overdose. It could be an accident while you're driving under the influence of alcohol. And the effects depend on multiple factors, including the coping skills and how severe it is. And I want to point out here, too, is that this is a disease, whether it's ongoing or it's a recurrent episode, it affects the client, any domain, physical, psychological, social, spiritual, economic, and the family. The burden can be tremendous on the family. Providers are affected. You know, clinicians can get frustrated. You have clinics that have to make money based on attendance, and people who relapse often won't come to sessions, so there's no reimbursement. Everyone's affected by relapse, not just the client. Our next section will be a brief review. Dennis Donovan is going to do a brief review of the evidence-based treatments for addiction.
Okay. One of the things that I think is important that there are a number of different approaches that have been developed across time to try to deal with addiction broadly and relapse more specifically. And there are a number of studies that have been developed and implemented that have provided an evidence base behind that. One of them that has been really, I think, influential is one having to do with alcohol, and it's the NIAAA funded study looking at trying to match individuals to different kinds of treatment. It's called Project Match. But essentially, there are a number of different approaches, and I'll talk about Project Match momentarily, but all of these things that focus on relapse really have as an underlying emphasis, one, trying to identify what categories of high-risk situations there are, the ones that were listed there, like negative emotion, social pressure, and so on. And then two, trying to help people develop skills that will allow them to anticipate, avoid, or manage those kinds of situations when they find themselves in them. So I think as you look at this, there are these ones that are listed here: coping skills training, the matrix model, which was developed initially for cocaine and then expanded for use with methamphetamine, relapse prevention therapy, recovery training, and self-help. Basically, all of these things have the same goal, and one of the difficulties is they're fighting against what is, in fact, the reality that many people will relapse despite our best efforts. So the question is, how can we implement these approaches to reduce those high rates of relapse? And as Dennis pointed out, the first 90 days represents the greatest window of risk, so that we need to try to find ways to sort of move people from that action phase into the taking steps, and as part of those steps, learning, developing, practicing, and implementing those coping skills that are necessary. So Project Match, just to briefly describe it, I was one of the investigators in Project Match, so it's near and dear to my heart. It was an NIAAA-funded study, the National Institute on Alcohol Abuse and Alcoholism. It studied over 1,700 alcohol-dependent individuals who received one of 3 different kinds of treatments, randomly assigned to these. One of them was a 4-session motivational enhancement therapy. It was the first time motivational interviewing was formalized and manualized as a therapy. A 12-session, 12-step facilitation approach, and then a cognitive behavioral coping skills approach that really was based on the principles, again, of relapse prevention, that people have deficits in coping skills, that part of the task is to try to train them up to improve the quality and capability and capacity of those skills that they have to deal with potential high-risk situations. Half the people received one of these 3 treatments fully as outpatient. That's all they got. And there was the concern early on in the planning process that how can you treat chronic alcohol-dependent folks with only 4 sessions of motivational enhancement therapy, and that's it. There were questions about 12 sessions of either the 12-step facilitation or the cognitive behavioral therapies and whether that would be sufficiently adequate. And yet what we found was that all of them seemed to be effective in reducing subsequent alcohol use, not just in the first year, but in a subsequent follow-up study, that those results, those reductions were maintained out to 3 years, and that these 3 treatments were comparable with respect to their outcomes when you looked at the reduction in subsequent alcohol use. People are able, by the way, who have interest in looking at or using any of these 3 Project Match therapies, that the therapy manuals are available at relatively small cost. I think it's like $7 at the National Institute on Alcohol Abuse and Alcoholism's website. But the one that really is related most specifically to the relapse preventive approach is this cognitive behavioral coping skills therapy manual. And what you find, just to reiterate what the results look like, that's what they look like. That initially, what you see is that in those -2, -1, and the 0, that's baseline assessment before the interventions are put into place. We're looking here at people who receive these 3 interventions as full-standing outpatient treatments. These are the only treatments they receive. It's not embedded in any other kind of more formal treatment program. It's a freestanding outpatient intervention. And what you can see is that the percent of days abstinent increases dramatically from the point of implementation on, and that those lines are as close as probably you can find among intervention studies, so that each of them has had an impact. Even the 4-session motivational enhancement therapy, the coping skills and the relapse prevention approach, as you can see, is also in there and is quite effective. And if you look at it, looking at the mean number of drinks, so before we were looking at the percent of days that people were able to maintain abstinence, in this case you're looking at if those people drink, how many drinks do they have, and what you see again is all 3 of them are dramatic with respect to their ability to reduce drinking behavior. So we have a number of treatments overall that are effective, one of which specifically focuses on relapse. Others focus on motivation and trying to get people to use those skills that presumably they already have but may be less motivated to do, and trying to engage them in that process. And the other is to get people to take advantage of the support systems and the support networks in the 12-step recovery community in a more active way. And as you can see, there are lots of different ways in which that can happen. So stop fighting and surrender Jones as your sponsor. All I ask is that you do 90 meetings in 90 days. This is not a motivational enhancement approach, by the way. This represents sort of a more traditional view of the sponsor who is forcefully getting people to go to those meetings when the individual may not necessarily want to. So a second large study is one that Dr. Daley was actively involved with, and he can help me if I get confused here. So basically, NIDA funded a large multi-site study of cocaine and its treatment. And it had 5 sites in it with nearly 500 people. People received one of 3 different types of treatment, individual treatment, and then also its combination, or their combination with group therapy. Or in the case of a control condition, they received group and case management, but not one of the specialized therapies. What you found, again, not unlike Project Match, is that there was a significant reduction in the cocaine use at the end of the year, and that the best of those combinations was one that combined individual drug counseling that focused on relapse and on 12-step engagement, along with group counseling. And it was more effective, that combination was more effective than group therapy alone or group therapy in combination with cognitive behavioral therapy or the other therapy, which was supportive expressive therapy. And as you can see here, again, implementation of therapy has a dramatic effect, and it often is the case that it's less the type of treatment that has an impact as opposed to being engaged in some form of treatment. Focusing on relapse and trying to engage and increase support seem to be key elements in most of those things that are successful.
Yeah, I just want to add briefly 2 other findings that were interesting. One was recovering counselors, their patients did not do better than non-recovering counselors. And also, if you were African American and had an African American counselor, you did not do better. The most important factor was therapeutic alliance, the connectedness between the clinician and the patient.
And that's actually the same thing found in Project Match, that therapeutic alliance carried more weight in improvement of clients than in the type of therapy that they received. So that one of the things I think a take-home message is that treatment is effective. Different types of treatment may be comparable with respect to their effectiveness, but it may be the individual who's delivering it and the bond that develops between the client and that therapist that has the greatest impact at some level. All of those things in a research setting have to be taken into account in all the analyses as well, which makes it much more complex. Another approach that we wanted to mention is one that may be less familiar to people, but if you're involved in the clinical trials network, it's one that's been evaluated in a number of different studies, and that's the use of motivational incentives. This is one in which individuals are provided with some kind of reward or a reinforcement for providing drug-free urines, if that's the target, or for attending meetings, and so on. And there's been controversy about them within the field because many people feel philosophically that one shouldn't have to, quote, pay, end quote, addicts to go to treatment or to stay clean and sober. And yet, it seems that this is one of the most powerful and most effective treatments. As long as the contingency is in place and as long as the reinforcements are being provided, it really does dramatically impact and reduce drug use or increase attendance, whichever the target may be. And what seems to be an important piece and where it may be most helpful is early on to help stabilize and initiate a period of abstinence. And it may be, as some programs have begun to do, that you combine the use of motivational incentives early on in treatment to help, in fact, initiate that abstinence, and then blend in relapse preventive approaches to help people make the transition both off of the contingent reinforcers, but also to develop the coping skills once treatment, the formal form of treatment, has ended, so that they're able to have both stabilization at the front end through the use of incentives, and then have the coping skills necessary to deal with the high-risk situations they'll face once leaving treatment. Also want to point out that as Dennis said, relapse affects families. Often described addiction as a family disease, both because of its genetic loading on the one hand, but because of the impact it has on families. And the other side of that is that family therapy is an important adjunct that we need to consider. One of the things that has been the case in clinical settings and in research is that there's something that's been described, Terry Gorski, who also is someone whose model of relapse prevention is prevalent in the field, it has talked about the bud signs or the bud symptoms, the building up to drink. And many times it's those accumulation of high-risk events or putting oneself in high-risk situations that as an individual he or she may not be fully aware of. And yet it may be the family members who are best able to observe and note that, in fact, somebody's building up to drink and help to facilitate some kind of an intervention to try to prevent that. So looking at family therapy is important, helping families to understand the relapse process and what role they can play in trying to help the client, again, avoid or cope with high-risk situations, or if relapse happens, that they're able to help the individual pull out of it more rapidly. I missed a slide. The other is sort of taking it from the family level down to the couples level. That behavioral marital therapy, which is based to a large extent on the development of coping skills in the context of partnership, communication, and sort of self and other reinforcement, has been shown again to be effective. But what's of interest is that the efficacy of this behavioral marital therapy is enhanced dramatically if one, in fact, adds to it relapse prevention, so that individuals know how to deal with, again, those building up to drink symptoms that they may see in their partner, and to help intervene in a positive way as opposed to a critical way to try to help prevent them from relapsing. Next section is on relapse prevention therapy or counseling. What are the common elements? So basically, as I said, there are lots of approaches that are based on sort of a cognitive behavioral view of addiction. And that view, to a large extent, assumes that individuals may be deficient in the coping skills necessary to deal with both interpersonal issues, the conflicts with friends or family members, to deal with the social pressures that are involved in a drug-using group, or that they may be deficient in those coping skills to regulate their own emotional feelings. And so if one looks at the kinds of things that are part and parcel of almost all of the approaches to try to facilitate relapse prevention, they look at the development of skills. And I've always said that often in clinical trials of relapse prevention, we're very good at relapse exposure training, but not necessarily relapse preventive intervention training. And what I mean by that is that it may be necessary to give people practice of these skills, not just to expose them, which often happens in short-term trials, but to give them exposure plus the opportunity to really practice and to become grounded in the use of these newly acquired coping abilities. They need to be able to manage high-risk situations, and they need to be able to recognize the warning signs. So part of our task is to help them figure out what are those for them. You know, who are the high-risk people in their lives with whom they've used in the past? Where is it that they go that is associated with their past use? And how is it they can learn what those signs are for them? In addition, it's not just stopping drinking or drug use, it's trying to increase one's breadth of activities that are reinforcing, that will fill the void once all of those drinking activities are gone. And to do that, it's necessary to look at and increase the healthy activities that one engages in, and ultimately balance the lifestyle. That one of the Marlat's notions is that one of the biggest risks is when one's needs exceed their wants. That there's often the tendency that we feel obligated to do things, and that obligation sort of takes away our ability to do things that we feel are rewarding and fun and we want to do. And with that is build up resentment that can contribute to it. So we need to learn to balance between the wants and the needs in our lives. And then if relapse does occur, how do we stop it? How can we pull out of it? How can we help family members assist in that process? How can we help the individual pull out in that process? And I think one of the benefits of relapse prevention is that it views a relapse as not the end of the world. It's an event and a course. And because of that, it's possible to look at it quite differently, and cognitive reframing then becomes an important part of that. That we look at relapse as an event, we look at it as a process, as Dennis mentioned, and in the process of doing so, we give people hope that this is not the end result. This is not the final course for them. So there are a number of resources that are available that can help. Two books with Alan Marlat as the primary editor. The original was published in 1985. Alan Marlat and Judith Gordon really presented the model of relapse as it has sort of been the foundation for many of these things. And then a subsequent revision and an update of that in 2005 by Alan Marlat and myself really provide information that's specific to different addictive disorders and provides both information about the addiction itself, that particular substance or behavioral addiction, and then the application of relapse prevention strategies for that. Dennis Daley has also published a number of things. One of this is a relapse prevention counseling manual that really is quite helpful. I actually began using some of Dennis's materials early on, running relapse prevention groups in an inpatient treatment setting years ago. And it really provides strategies that are very practical and useful, and as can be seen here, it really sort of lays out lots of the information that clinicians can use to put in place groups that can really teach about and give people the opportunity to practice those coping skills necessary. That NIDA has made available a number of resources as well, so that you can look at and see, in this case, a recovery training group session that has 23 sessions involved in it, so that you can sort of pick and choose those that might fit well in the context of your clinical program. The matrix model that comes out of Southern California has a manual that really is quite excellent, and relapse prevention is a component part of that. But what's nice is that with the matrix model, it also talks about some of the issues specific around the early recovery process and sort of stabilization and sort of coming out of the fog, if you will, of being intoxicated, usually with either cocaine or methamphetamine. And then some of the other things that are important that include, again, trying to facilitate involvement in social support networks in the community and engaging the families. So just to let you know that there's lots of background research that's been done in the area to help support all of these approaches. So when we present them as evidence-based practices, there is in fact evidence behind them, that these reviews, both the clinical trials as well as subsequent reviews and meta-analytic analyses, have really demonstrated that relapse prevention and cognitive behavioral therapy are effective approaches. They have demonstrated efficacy in both individual counseling, in group counseling, in the behavioral marital therapy. They've been used in combination with medications, some more effective with certain medications than others, and that there's been this study that NIAAA funded, the Relapse Replication and Extension Project, that really looked at, again, the categories of the relapse precipitants and reaffirmed the importance of those and the validity of that whole classification approach, and suggested a number of methods to assess relapse risk. So if people are interested, there's, I think, in the material that you were sent, a bibliography and a list of references in which you can find a number of the supporting research studies and summaries of those studies. But I think the take-home message is it's one of the most studied and one of the most efficacious interventions that we have, both in relapse preventive work with addiction, but also, as Dr. Daley alluded to, in psychiatric care as well.
Okay, the last 35 or 40 minutes, we'll go over 16 interventions, 6 related to system strategies and 10 related to individual counseling strategies, although some of the system strategies can be done in individual sessions as well. And these focus on issues like adherence, going between levels of care, from detox to rehab or rehab to ambulatory, using incentives, medications, family, and then looking at co-occurring. So I'll speak about these briefly because Dr. Donovan had mentioned some of these before, especially the incentives. And when we talk about systems interventions, we're talking about these are interventions that are tied into a program. You know, I remember when I went to my first training in Hazleton decades ago, that Dr. Anderson, who founded Hazleton, talked about the importance of programs having a philosophy that the clinicians and the staff agree upon in delivering services. And I think that's important when you're looking at these issues. So, for example, it helps for treatment programs to, let's take an outpatient program. How do you think about adherence? What do you expect from clinicians in terms of adherence rates for the individual session, the initial evaluation, or follow-up session? What do you do when you have low rates of attendance? So, for example, we studied this for a number of years and found out there was a huge range of differences. One clinician would have 42% of sessions attended. One clinician would have 70%. So what were the differences, and what do you do about that? So when you look at this from a systems point of view, you can do a lot of things to help your clients. Let me see that. The first one is looking at adherence, and we had mentioned motivational incentives. Just to give you one example, we have a co-occurring program, a partial day program. People come in 5 days a week, and we used incentives, and we improved attendance by 60%, which was very significant because if a patient doesn't show, we don't get reimbursed for that. Attend to the Therapeutic Alliance, and by that I'm talking about, I think we learned a lot from cognitive behavioral therapy, which is you talk to the client or patient about how are we doing, are we focusing on what's important to you, any concerns you have about our work. Similar in a group, you can ask a group because a lot of treatment and addiction is delivered in groups. You can ask a group, how are we doing? Are we focusing on what's important to you? What would you like to see different? Preparing client for treatment. There's a whole literature on treatment induction or psychological treatment, psychiatric treatments. The same should hold true for addiction treatment. If you send someone to a partial or an IOP program or rehab, they should have some sense of what goes on and how to use the treatment. So, for example, teaching about the importance of self-disclosure, about the importance of sharing some of your feelings or your thoughts and your problems, with your treatment group. Collaborating with the client on the treatment plan. They should have input on what you're doing. That's very important. And then take a look at, are you using evidence-based practices and treatments? Are you adapting these to your clinical population? Clearly, today we're much more conversant with evidence-based practices than we were decades ago. I remember doing workshops 15, 20 years ago and mentioning Project Match, and maybe 2 or 3% had heard about Project Match and some of the treatments that Dr. Donovan had mentioned. Now that's increased significantly. And I think it's good for people to have at least one or two practices they feel very strongly about, they feel well trained in, and then they can branch out and learn other practices as well. And it's good to develop guidelines on adherence. You know, what does your program want? Ask clinicians. When we did this with clinicians, they said, well, why don't we try to get 70% attendance on scheduled sessions? Let's see if we can do that. The second intervention is to help people go from one level to the next. And it can be hospital, residential, or detox to the next level of care. It could be ambulatory, it could be detox or residential, or any active treatment to continued care. That's important. The transition period is where you have a lot of dropout. When people leave one system, they fail to go to the other system. And so that's important to look at. How do we help people make sure they follow through? So, for example, if you look at some of the continuing care data, what you find is that the longer people stay in aftercare, the better they do. And we know that. People in recovery know that as well, who attend 12-step meetings. So what these show is the first one shows that people do better, and the second one shows the days absent. So you see a significant increase in the days absent for people who spend more time in treatment. I think Dr. Donovan had mentioned this before. Same thing, they drink less. If you stay in, the longer you stay in treatment, the better you do. We looked at patients with psychiatric illness and substance use comorbidity in a psychiatric hospital. So, and they're a little different than a lot of patients, and they have more diagnoses. They have a greater severity of history of days in the hospital, number of diagnoses, days in rehab, days in detox, and so forth. And we found very low rates of attendance. We found, depending on the cohort we looked at, in the diagnoses, we found about a third or a little more than a third show up. There were some studies of people with schizophrenia in addiction that about 20% show up. So we used a simple one-session motivational session. We took some of motivational interviewing and some of our adult diagnosis focus, and we developed a single session, and then we gave it to the patient before they left the hospital. And we tried it in small groups or one-to-one, and it didn't seem to matter. Both seemed to work. That you can see a significant increase. If you look at the non-random group, it went from 40 to 63%, which is a significant increase. When we had a clinical trial looking at outpatient treatment, where everyone got the session before they left, that went up to 76%. So I think what this shows is that we can do things differently to prepare people for the next level of care. Now, I won't go into the details of what we did just simply because we have too much other stuff to cover, but suffice it to say, if you have a person back multiple times, don't do the same damn thing. Do something different. Focus on, what is it that led to you not following through, when you left the hospital? Because if someone's been in the hospital or detox 5 or 10 times and they never follow through or seldom follow through, that should be a main focus of your treatment. Dr. Donovan talked about motivational incentives, so I won't mention that. We know it's a very helpful intervention. It's been used with many different types of problems, very effective. Now, this is important. When we're talking about medication-assisted treatment, I'm not referring just to opiate substitution therapy with methadone and buprenorphine. You also have medications for alcoholism. And what I've found over the years is that a lot of clinicians don't routinely think about medication-assisted treatment. If you have an opiate addict, it's fairly typical if someone's had multiple episodes of treatment failure to talk to them about methadone and buprenorphine. Same doesn't hold true with people with alcoholism. What I'm saying is, if you have a patient with alcoholism and they've had trouble with the sobriety, talk with them about the different medications. That's our role as caregivers, to look at these are the different tools to aid your recovery. And we pretty much promote the use of medication with psychosocial treatments, and they do help people stay in treatment longer. They help them get abstinent, stay absent. They help reduce relapse rates. They tend to relapse less severely than others. And they also help them stay committed to meeting the goals. And keep in mind, as we said before, that first year, and within the first year, the first 90 days is the most difficult time. So you can use medication-assisted treatment early on as a way of helping people stabilize. And this just tells you a little bit about the types of medicine approved for alcohol dependence and opioid dependence. There's a lot of medicines that have been tried for cocaine dependence. Nothing's been approved by the FDA, but several studies are going on looking at vaccines, looking at medication, same way with marijuana. Plus, we know there's medication to help with nicotine dependence. And although we haven't talked much about that, that's an important intervention as well, because a lot of our patients with alcohol and drug problems have nicotine dependence as well. And here is a website where you can get a free PDF file of a booklet on medication for psychiatric and addictive disorders. The only thing you have to watch for is that since medications change over time, there may be some new additions. I think this is about 2 or 3 years old, but medication certainly can help reduce the risk of relapse. Dr. Donovan talked about the family. I won't go too much into detail other than say you do not have to be a social worker or family therapist to help a family. Talk to patients about the impact of your addiction, the impact of your relapse on the family. Talk with them about how they can work with the family. Invite the family to a session. You don't have to be a family therapist or social worker to talk to a family. There's a significant burden. People get hurt. Families get emotionally distraught when they have to deal with a relapse. There's all kinds of stuff that goes on that we have to think. If we want to treat addiction as a family disease, then damn it, we have to think about families. So my message to all of you is, if you take 1 of 5 points away, one of the points you should take away is, how are families affected by relapse? What can we do to help the family as well?
And I think, again, the other important part is family do as a way of helping the client prevent relapses. Or if relapse occurs, how does the family help that individual pull out of it?
And that's a good point, Dr. Donovan. And I recall in a previous program I worked at where getting families involved in learning about relapse prevention, some of the stuff we're talking about, that there were, I think I kept track of maybe 15 samples, and every relapse or lapse was stopped within a day or a few days or a week, whereas before they might go on for months and months and months. Because the idea to tell families is you can take action, you don't have to be passive and, let this pull you down. And so these are just some of the adverse effects on the family, the system as a whole, as well as individual members. I mean, there's a whole extensive literature on adverse effects on family systems and individual members. And I don't think you can work effectively in the field of addiction medicine treatment if you don't think in terms of family systems and individual members. The next intervention is looking at integrated care for co-occurring disorders. And what this means is that when people come to an addiction program for treatment, you have to take a look at whether or not they have a co-occurring psychiatric disorder. That does not mean if they're a little bit sad or depressed, they have major depressive illness, or if they're a little bit hyper, that they have bipolar illness. The two extremes we want to avoid is overdiagnosing and underdiagnosing, because I have seen cases, I remember I've seen cases where both happened. A young man came to see us and had severe depression and severe cocaine addiction, but was doing well with the cocaine, but actually had gotten more depressed, and said to me, well, my counselor doesn't believe in medications for people with addiction. And I figured, well, what the hell, maybe the patient's not telling the truth. So I got permission, talked to the counselor, and it was a well-meaning counselor in terms of doing good work on the addiction, but she had this belief about using medications for anything. And to make a long story short, we couldn't help him effectively until we got him on an antidepressant. So assessing for psychiatric disorders, providing integrated care, and by the integrated care we're talking about not just the medications, but the psychosocial interventions as well. And a lot of the interventions we use with a lot of disorders, like helping people change their thinking or deal with relationships or deal with emotions, it's relevant to co-occurring disorders as well. And then one of the unique interventions for the more chronically impaired, with people with chronic mental psychiatric disorders or recurrent disorders, are to help them monitor the psychiatric symptoms or persistent symptoms over time, because, for example, someone with schizophrenia and addiction may have to learn to live with hallucinations, but it's a matter of degree. So if you can teach them how to monitor the symptoms on a regular basis and know when to ask for help if the symptom exacerbates to a certain degree. So, for example, some people with schizophrenia and addiction have to learn to live with hallucination. But it's one thing to hear a voice that you can just ignore. It's another thing to hear a voice that's torturing you. And so the latter requires some other type of intervention. And this is just, we developed an integrated model 20-some years ago, and actually a manual as well. And we've been using integrated treatments for decades, and you see more and more in the field, which I think is good, because the patients we see in psychiatry, you have high rates of substance use comorbidity. and vice versa. In addiction settings, you have high rates of psychiatric comorbidity. Now, the last section, we have 10 interventions on counseling, and Dennis will do the first 5, and then I'll do the last 5.
Okay. I'll get my slides up here. All right. One of the things, again, that we've talked about is the importance of initially identifying and then being able to manage situations. And the reason that that's important is Pavlov and his dogs were right. And what I mean by that is that there's a conditioning process that individuals who are addicted have been exposed to situations that when they go into them, it pulls forward craving. And so one of the things that we found is that craving represents one of the primary triggers to relapse. If that's the case, we need to figure out what are those cues that trigger initially the sense of craving. So as clinicians, part of that process is what are the internal things that the individual is dealing with emotionally that have been conditioned so that when they begin to feel those emotions, it starts to swell up and be experienced as craving. Help them to identify those external things, you know, the people, places, and things that people have talked about that really represent high-risk situations for them, either interpersonally, again, with people, or situationally in geography and place. So that, you know, going to pay off your bar bill in the tavern where you've done all of your drinking on a weekend pass from treatment probably isn't a good idea, in large part because you're going to be there in places where you've done things with people, all of which have high-risk connotations involved. So you need to look at and help individuals identify what is it that's going on, which of those situations are of risk to them, and what is it they can do about them. And many of them are ones that they're less aware of. So some we can easily identify, but others it's going to be up to them to begin sort of introspecting and looking at where it is they go and what they do to begin to see the patterns. So let's just go in and see what happens. It's sort of like going in to pay your bar bill when you're trying to stay clean and sober. How can you manage some of these things? Well, first you need to recognize them, and you need to be able to label them. And one of the things that's important is that many times people misrepresent feelings of anxiety and sort of an uneasiness in those situations as craving. And if one can differentiate and help people see that they're anxious because they're in a high-risk situation versus I'm feeling craving and I have to give into it, that's an important labeling process that's useful. Get them to put it in words. What is it that they're feeling? What is it that they're craving? Is it really craving? Help them to look at the use of the support groups in the treatment environment or in the community where they can talk about what's going on with them. When they experience those, have them try to look at other things they can do. You know, if one starts to feel sort of uptight, anxious, and feels craving, first get out of the situation. You know, go take a walk, sit down and try to read a book. Difficult to do, but people are able to do so. One of the ways to help identify craving is to keep diaries. So when does it occur? When is it higher? When is it lower? Who's there? What's going on? What are the situational cues that are involved? And then figure out ways that you can either avoid the situations or those environments, or you can change them so that they become less risky for you. Reading recovery literature is important because it provides, you know, one of the things I appreciate about many of the AA sort of sayings is that there are some really important messages there. You know, shit happens, people, places, and things, all of those kinds of ideas keep people focused and begin to allow them to look at what's going on in their lives. We here have talked about sort of urge surfing, sort of viewing yourself in an imaginal way as sort of riding the wave of craving as it sort of rises up, much like you would be surfing on a wave, and then being able to see that the wave itself passes, and you're able to stay standing on your surfboard. Dennis Daley has talked about crushing the craving, having images of people sort of being in tanks or big trucks, and when they see themselves in a craving situation and sort of visualize the craving, sort of run right over it and crush it and sort of put it out of its existence and your existence as well.
That reminds you of the Steelers crushing the Seahawks in the Super Bowl 40?
I thought I'd get through an hour and a half without a reference to that.
Okay, sorry about that.
Oh, that's okay. I'm sure you're sorry, Dennis, as you are each of the many times you've pointed that out. So the next is look at and challenge the way we think about things. You know that many times people look at themselves as having no control. They view things as being outside of their control. And really, part of what we need to do is to help them reframe lots of this. That, again, craving can be reframed as uncomfortableness in high-risk situations. We can begin looking at the fact that as they acquire these new coping skills, along with that comes an increase in self-efficacy, the sense about their ability to take on the challenges of these high-risk situations in the future and cope effectively with them. We can change the outcome expectancies. One of the things that happens is that many people develop expectancies about what they believe alcohol or drugs will do for them. And typically it's in a positive way. It will help me socialize more. It will help me deal with my depression. You know, I will become a funnier individual. I will be able to, do a number of different things under the influence of alcohol. And yet, there are many downsides to the use. And so we can begin to get people to challenge the positive nature of those anticipated outcomes that they view that have reinforced their use, and instead begin to get them to look more realistically at some of the things that go on when they do use. And the other is that many times people have this sense of loss of control, and it's this attribution of causality. There's a tremendous amount of research that suggests that loss of control is much more regulated by what people believe than the actual substances that they use. And so, again, part of it is to give people a belief, and a true belief, that things are not necessarily out of their control, that they have the ability to sort of do things differently and to cope, that they have increased self-efficacy to do so. We improve cognitive coping skills, looking at how thinking plays a role, sort of the rational recovery notion, and Albert Ellis and that whole notion about how it is that how we think helps to define what it is we feel, that we need to get people to look at their negative thinking abilities, or their negative thinking styles, rather, and to really change the way in which they look at themselves and they look at their world. They need to look at cognitive distortions, those things that really aren't accurate with respect to how they view themselves and their situation. And most importantly, I think, is to teach problem-solving skills. That many people, because in fact alcohol and drug use early on especially sort of keeps people from acquiring many of the skills that are important downstream, one of the ones that's often missed is the ability to sort of analyze problems and solve them effectively. And the other of these two characteristic sort of notions that come out of the relapse prevention model, one is an abstinence violation effect, that people believe that if in fact they drink or they use drugs after a period of being clean and sober, that it's the end of the world, and that there's this negative emotional state that sort of overwhelms them and they give into, and that's one of the reasons that they would continue to use. And in fact, that need not be the case, and that there are ways in which people can be taught that relapse is a teachable moment, and that they can learn from it. It's not the end of the world. It's one part of the learning process and the recovery process, and it need not be devastating, and there are ways to pull out. Secondly, apparently irrelevant decisions are ones in which people make decisions that on the face of it from their perspective, in a somewhat distorted way, they don't think have anything to do with ultimately their subsequently relapsing. And yet, there are decisions that they make that lead them into situations that have increased levels of risk associated with them, and in fact are part and parcel of this building up to drink syndrome that's talked about. So that we need to begin to look at the decision-making process that they have and point out how it is that these apparently irrelevant decisions, in fact, are quite relevant. They need to be looked at more effectively as a way of preventing relapse from occurring. Negative thinking, I'm an old man and have known many troubles, but most of them never happened. It's in our head, not necessarily in what happens to us. So we need to challenge our thoughts. We need to sort of look at them effectively, and in the materials that we showed you earlier in some of those manuals, there are very specific ways that are outlined that you can do this and help clients to do it. We need to look at the warning signs along the way. One of the things that Alan Marlatt and others have done is they've sort of developed a map of the road to relapse, and that there are forks in the road along the way in which we have decisions to make. And in many cases, again, the apparently irrelevant decisions individuals make lead them down the path toward relapse. And in fact, we have the opportunity to try to remap. It's almost like we are helping our clients develop a new GPS system, so that, in fact, it takes them in a route, and their decision-making allows them to move forward along that route toward a much more productive and better quality of life downstream by the ability to avoid those situations that have many pitfalls along the way. So,
Dennis, can I interrupt you for a minute?
Sure can.
Speaking of pitfalls, I think we have about 10 or 12 minutes.
Okay.
We want to do the last one, so we may want to be a little brief just so we can cover these with the understanding that everyone has the handouts and references for more information, because there's just so much to cover. We actually got a little bit too ambitious.
So, at a brief intervention? Okay. So, warning signs we've talked about. Learning from relapse, again, what is it as a teachable moment you can learn? What happened? Where was it? Who was there? What do you need to avoid in the future? Examples, again, this is something that you can see in the material that we've referred you to. There are specific ways to go about this process. Identifying and managing high-risk factors, to a large extent we've kind of talked about this, but as a model, just to point out that if one sort of is in a high-risk situation and going down along the bottom doesn't have coping skills, it leads them to feel as though they're more vulnerable and they have a decrease in that sense of efficacy. It makes using drugs more positive. The expectations increase, they'll use, and then these other kinds of attributions come in, and the likelihood is that they'll continue along and relapse. Our goal is to try to take the upper route, where we give people appropriate coping responses, their efficacy is increased, and we decrease the likelihood of relapse. And these are the situations, again, that we sort of pointed to earlier on that are important to look at. Negative emotions, social pressure, interpersonal conflicts, the urges, cravings, and temptations, and positive emotions. So, having looked at emotions, part of what we have to do is, again, realize that many people don't have the necessary coping skills. We need to look at ways of trying to give them what it is they need to do more appropriately to regulate negative affect. And really what we're talking about in this case is anxiety, boredom, depression, sort of that feeling of emptiness, and one that's not here is anger, which is another of the big factors emotionally that contributes to relapse. And basically, again, the most important thing is to help individuals learn to cope more effectively with the negative emotions and also to increase their ability to experience and generate positive emotions. So I think with that, I hand this back over to you, Dennis.
Okay, I'll do this briefly because to be respectful of time. Remember, the second most common precipitant was social pressures, so we want to focus on that, helping people to identify the direct and indirect pressures, but more importantly, how do these affect the thinking, the emotions, and the behaviors, because those responses determine how we think and feel, determine what we do with the social pressure. Who should be avoided? You can't avoid everyone, but some people should be avoided. Very importantly, the coping strategies. Practice, practice, practice. Lots of people will talk about, they've had these discussions in therapy groups or treatment groups, and they don't do any practice. So you can set up behavioral rehearsals where people are offered drugs or alcohol, and you can help them learn how to say no, different ways of using the voice, different ways of using language, different ways of ending a conversation, these sorts of things. Practical behavioral skills. And I did want to mention, and we had this on one other slide, that since a lot of us do groups, that you really need a lot of different strategies to go over the material here or other basic material on addiction. Lectures, interactive discussions, you want to use videos, you want to use role plays with group watching, you can use alter egos that express what the client in the role play is thinking but not saying. You could use dyads, you can use music, you could simulate bars, you could use simulated joints, all sorts of things. But the important of that is that if you're doing the same group topic over and over and over, you get a little bit tired and bored. So the more you can expand your repertoire of how to do a particular type of group on a topic, a relapse topic, the better for you and for your client. The social network's important. We know that people who have better networks do better in life in terms of whatever the illness is, medical, psychiatric, or addiction. The big issue is ask for help. 70% of professionals I work with, if I ask them, how difficult is it for you to ask for help, about 60-70% will say, yeah, we expect clients to do, but we don't do it as well. So you want to think about why is it hard for us to ask for help and why might it be hard for clients as well. Even something as concrete and practical as asking for a sponsor. You might be shocked at how many clients don't know how to do that. What do you do? What do you say? How do you approach someone? And so some things to do is looking at the support system, who are the friends, what mutual support programs, what are high-risk people, what are some of the barriers, that might be I'm embarrassed, I'm humiliated to ask for help, or I think I should work out everything on my own. And then teaching clients how to ask for help. This gets into the practice, the behavioral rehearsal of the practice. What are some conflicts they're having with others or families? What are some of their interpersonal strengths or deficits? And then there may be specific social skills that they can benefit from. How to be more assertive, how to communicate what they want to do, how to communicate even something as simple as saying, no, I don't want to use that cocaine. And then anything you can do to enhance relationships, because people with stronger relationships and support systems do better in recovery. Related to this is facilitating involvement in mutual support programs. Dr. Donovan has done an outstanding job summarizing literature for the CTN 31 on mutual support programs. And basically, what's been found is that if you can get people to be active, not just go to meetings, but to do the things that we think are important, get a sponsor, work the steps, use the recovery literature, use the slogans, use the tools of the program, they do better. But you just don't want to give a meeting list. You want to have a discussion. You want to facilitate that linkage. If you have if you have access to buddies or people in recovery who can take people to meetings, that's another good intervention as well. And so this is just a workbook Dennis and I wrote for use. It was a supplemental publication we used in the CTN 31. It's just to educate clients on 12-step programs and get them over some of the resistances. Now, if you look at the guy on the left, if you look at that beard, it looks like Dr. Donovan's beard. It was a little longer. So I think did you shave it off? I hope you shaved it.
It's gray now instead of orange.
Well, if I could grow a beard, it would be gray, too. Dreamt I joined a 12-step program. This is one of Dr. Donovan's slides. He's got the greatest slides on cartoon slides you can imagine. Here's another one. Jones would walk through a blizzard to get his dope. The question remains, what will you do to get to a meeting? So Jones has finally surrendered. And so these are just some of the strategies. What are the barriers and benefits? What we found is that if you expect to reach people only talking about the benefits and don't let them talk about what they don't like about mutual support programs or the barriers, you may lose them. And so these are some other things you can do. Lifestyle issues, we won't go through this just because of time. You can just read the slide, but obviously, you know, Dr. Donovan mentioned some of these things. You have to have healthy activities and things you do for leisure time. But the last thing I wanted to mention, which is very important, is stopping a lapse or relapse. That's a critical intervention because you have high rates of lapses and relapses. The earlier you can intervene, the better. The more you can help people learn about what decisions they made that was connected to the lapse or relapse, the better. Have people and groups learn from each other. So if someone has relapsed and they're stable from the relapse and they stopped it, you know, they can go over the risk factors or warning signs with others. What I often do, we'll have a client, I will have a group interview the client who has relapsed so they can learn from him. So what you're doing is you're reframing a quote-unquote failure experience to a learning experience. So these are just some of the concepts that Dr. Marlotte talked about the coping with the lapse, and just some strategies here that are very good. I think, you know, my summary comments are just that regardless of where people are in the continuum of care and treatment, there's a lot you can do in terms of educating people about relapse issues, and very importantly, as Dr. Donovan and I have stressed throughout, the more you can focus in on specific skills a given client may need, then you prepare them better for long-term recovery. So I'm going to skip this just because of time and then let Dr. Donovan just summarize a few points.
Yeah, I think, again, what we wanted to try to do, and I'll go over what are important aspects here. One is to educate people about the relapse process, to help identify high-risk situations. What are the personal warning signs for the individual client for relapse? Those people, places, and things that are associated with the likelihood of relapse. Developing and practicing, I express the practicing of these strategies, the coping strategies that deal with both substance-related as well as other life problems, and helping to develop problem-solving skills. Increasing the perception the individual has about his or her self-efficacy and competence to deal with situations in a meaningful way, and in so doing, help reduce the risk of relapse. Most importantly, beyond that, once stabilization has sort of occurred, developing new lifestyle behaviors, expanding one's horizons, expanding friendships and shifting friendships from users to non-users with whom you can do things, and then being able to anticipate, to try to avoid, or to try to deal with relapses, and if they occur, to again have the coping skills necessary and the social support systems in place that can allow you to get out of those quickly. So that's it. I did see one question from Paul Joaquim that said, missed the examples of internal triggers. Those really are much more the internal feelings and emotions that we have, so that often if people begin to feel depressed or they feel anxious or they feel pressured, that for many of them, the idea of using alcohol or drugs as a way to cope with those internal emotions, usually negative ones, or negative thoughts that people have, sort of the cognitive internal triggers, sort of thinking about oneself in a negative way and feeling as if alcohol is a way of sort of, making one's view of the world and oneself different in some ways. Those are the kinds of internal triggers that we're talking about. They're emotional and cognitive in nature, as opposed to the high-risk situations that involve people outside of you, or situations like the places that one might have frequented in the past.
Well, thank you very much, everyone, and just remember the work you do makes a big difference in the lives of many people as well as their families, so never forget that.
Hey,
Thanks very much. I'd really like to express appreciation to Dr. Daley and Dr. Donovan for giving us their time today. I want to remind everybody that we do have a webinar coming up next month on August 10th on the Certificate of Confidentiality. We will be distributing an email with a link to a survey if you would like to provide an evaluation on today's webinar, or if you would like to provide a topic of interest for next year's webinars. Thanks, everybody, for joining. And if you have any questions as follow-up to this presentation, you can feel welcome to contact me via email. That's ebatria@ms.com, or you can contact ctntraining@ms.com. If you know of anybody who has missed today's presentation, the presentation can be accessed within the next couple days from the CTN Dissemination Library or from the training section live link. Thanks, everyone, for joining, and I hope you have a great rest of your day.
Thank you, Liz.
Drs. Daley and Donovan.
Thank you.
Thank you. That does conclude our conference call for today, everyone. We thank you all for your participation.